During that talk, I really went through a little bit the background of pain in sickle cell disease. I talked a little bit about what components people should be thinking about when making pain action plans. And that includes both non-opioids, opioids, special opioids like buprenorphine and methadone, as well as resilience skills and complementary therapies. I think the main take home of my presentation was, again, thinking about those pain action plans and how every patient should have a pain action plan. And that it shouldn't only revolve around medicines, but those resilience skills as well as complementary therapies. When it comes to some of the medications, I think we're very used to a general pain treatment algorithm where we start with non-steroidals and then move up to maybe opioids and both weak to stronger opioids. And you know, it's somewhere thrown in there are sort of some complementary therapies like heat and hydration maybe, and then the use of other types of therapies like NMDA antagonist. And I think, you know, we should be, you know, incorporating those into the latter more, not just as, you know, off the side in some populations or special off the side medications and therapies. You know, talking specifically about some of the medications that I mentioned during the presentation, I talked a little bit about the special opioids, and you know, one of those is buprenorphine that we're seeing used more and more within other chronic pain syndromes and as well as sickle cell disease. You know, typically it's used as a substance use disorder medication, but could be very helpful for individuals who have increased acute care utilization. Could also be helpful in individuals who are on chronic opioids, just given its properties. It has a long duration of action, and it has very high affinity, so it kind of knocks off the other opioids off the receptor. And then lastly, it's a partial mu agonist, so it really keeps the patient steady as opposed to highs and lows when it comes to therapy.